Go through our lumbar spine rotary technique, also known as the Mamillary technique, based off our hand placement and differentiating it from essentially our somewhat neutral gapping technique of the lumbar spine. Okay, so height of the table, again, around VMO height. I, for one, like to get as much leverage as I can, so I usually bias it a little bit lower than higher. So to each his own. Okay, so the positioning of the patient to the edge of the table is going to be about 2/5 width away. So I'm going to have you're going to scooch up towards me. Very good. So I actually feel her touching me. Okay, so you know, I would say that a lot of manual-based, like certified orthopedic manual therapy, and even the NIOMP group will have you come here and do your neutral gapping and try and essentially like side bend and try and isolate the segment. Evidence in my that I'm familiar with would suggest that it doesn't matter, because we can span anywhere between plus or minus 5 centimeters from that target segment. And my hand placement is going to be more specific rather than just biasing her into the flexion. That being said, I am going to bias the amount of flexion that I put her hips into and her pelvis into based off how much mobility that her spine has, right? And so if we just appreciate that, even just observing her spine, right, is that it seems to be quite more mobile than most, right? So it kind of sags just naturally as because of the vector of gravity and her positioning on the table. And so we may need to, and I think I will actually try it with the slight modification of a towel roll under the, just over the iliac crest, and then under the 12th rib. Is that okay?
Yeah.
Is that too uncomfortable?
Nope.
Great. All right. So then we're gonna keep her flexed here, and her bottom leg is gonna go straight. And then notice how she wants to roll forward, and I really don't appreciate that, because that's the vector that I'm going to use to thrust into. And so as a result, I'm just going to scooch that hip under her so that she's more balanced and can remain in that position irrespective of me touching her or holding her there. This is important because it's rotation, right? This leg would block my thrust if it was not off, if it was on the table, and so I position that off. Okay, and I'm not going to overly rotate. I'm going to add a slight rotation. If you ask me how much, I'd say about 30 degrees. And I'm also going to flex and add flexion as I go through it. So she's just going to wrap her arm around me. I'm going to I'm going to flex you like that. Yep. And then this hand's going to go behind her head, and then this hand's going to go just like that. And then again, she should be relatively balanced. That looks pretty good to me. I would say I may want a little bit of more rotation. All right, and then I usually bias, I tell them, hey, you're gonna feel the edge of the table like you're gonna fall off. Don't worry, I've got you, you won't. Take a deep breath in, deep breath out, and I'm gonna add a quick thrust. All right, so my hand placement, so if I was to come and palpate, right, so we got the top of the iliac crest, and I'm gonna come over for my target segment is going to be L5-S1 or L4, L5, right around there. And my contact is going to be my pisiform process. And I'm just going to come just like this. And I'm going to roll her entire person and body as a single segment or log towards me to the point at which her pelvis, if this is vertical or orthogonal, I'm going to wait until it's about 45 degrees. And then I'm going to drop ASIS to ASIS, and my thrust is going to be not here. My short lever is this, and my long lever is my pelvis on her pelvis. We're going to go ahead and come out of it just because I've had you there for a minute. Okay, so those are the mechanics of the setup. Any commentary, any questions before we actually execute the thrust?
I think